Good morning, I'm Noelia Bravo. I'm fourth-year resident of gynecology in General Hospital of Segovia, Spain. First of all, I want to thank the organizing committee for giving us the opportunity to present our work titled Changing Concepts in the Management of Elderly Women with Breast Cancer. We have realized that elderly people represent a high percentage of the new diagnosis of breast cancer. In our hospital, they represent the 46% of the new annual cases, and these tend to increase. By 2035, up to 60% of the new diagnosis will be made in women over 70. It's a fact that mortality rates in breast cancer have improved in all age groups, but if we analyze it carefully, we realize that this improvement has been smaller in this population. This could be explained because the particular characteristic that has this population, more comorbidities, frailty, polypharmacy, low life expectancy, tumor biology differs from the younger women, which leads to a slower course of the disease. The second issue is that the scientific evidence available is limited as they are underrepresented in clinical trials. So it's difficult to standardize their treatment. And in fact, there's no consensus on the age cutoff point to consider a woman as elderly. It varies between 65 and 75 years old between the guidelines. So for all of this, we have performed a literature search, and we have selected an article related to the main topic published between 2009 and 2019, with the objective to unify criteria to optimize the management and the treatment in this elderly population. We are going to establish the age cutoff point in 70 to consider a woman as elderly, just to be conservative. But this elderly group is so heterogeneous and it's so wide in terms of age. So we cannot deny our treatment based only on the age criteria. We have to identify those patients who are going to benefit from the systemic therapy. For all of this, we have some tools. The clinical pathological factors are not enough, since small tumor could have a significant metastatic potential, and many patients will match the systemic treatment criteria, which entails a poor benefit in their survival with loss in their quality of life. So for this reason, risk prediction models have been developed. The two main examples are the adjuvant online and the predict. They both estimate the individual risk of developing a disease or dying within 10 years. So they both estimate the survival and the expected benefit from the systemic therapy, chemotherapy, hormone therapy, and in case of the predict, also of the trastuzumab. But the only one that is validated for elderly population is the predict. We have already mentioned in the presentation that this group have some particular characteristic. They have a lower physiologic reserve and organ-specific changes that may limit the tolerance to the treatment. So, to evaluate all of this, we can complete the study with a comprehensive geriatric assessment. It's a multidimensional method that studies the most relevant geriatric domains and tries to rule out frailty and functional impairment. The problem is that it's time-consuming and that it should be performed by trained staff. So, what could we do? Some authors have proposed to perform first a screening test, and in those patients who test positive, complete evaluation with the CGA. There are a lot of screening tools. We have selected the two, the geriatric 8 and the Vulnerability Elderly Survey 13. The first one is created and validated for elderly people with cancer, and the second one try to predict the functional decline and is validated for elderly people, and it's endorsed by the National Comprehensive Cancer Network. So with all of this, we have enough information to know if we are facing a fit patient that should undergo the standard treatment, a frail patient that maybe need a tailored treatment, or the dependent patient that will benefit from, depending on their life expectancy, hormone therapy or palliative care. What about the treatment? About the surgery. Conservative breast surgery should be the standard of treatment because it improves the overall survival, the local control, and the progression-free survival. And in those cases, when we can perform the conservative surgery, for example, multifocal disease, T4 stage tumors, neoadjuvant systemic therapy is recommended as an alternative to mastectomy. About the axilla, age is not a contraindication for surgery, but is no longer recommended because it doesn't improve overall survival. Radiotherapy is a bit controversial because many studies have shown a reduction in local recurrence, but this improvement is smaller in this elderly group. So we need to treat more patients to see that benefit. And we have to balance. On the one side, we have a population with higher mortality risk, but with lower intrinsic risk of local recurrence. But on the other hand, we have that it's a technique with a good result and well tolerated. So we need to individualize. Some authors propose to avoid in elderly people with a small tumor and positive hormone receptors. Aging should not be a limiting factor for chemotherapy, but some studies have shown an association between cumulative negative effects and the chemotherapy vulnerability. So before starting the treatment, we need to perform a CGA, and then we decide the chemotherapy. And about hormone therapy, during many years, there have been a tendency towards omitting conservative surgery, advocating primary hormone therapy. But this is no longer recommended due to design biases in these studies. So the gold standard should be surgery plus hormone therapy in case of positive hormone receptors, and only employ primary hormone therapy when the life expectancy is limited, or a patient who do not want to undergo surgery or are not good candidates for it. And to conclude, this is the algorithm we propose for the management for elderly women with breast cancer, which summarize everything we have already mentioned. Start the evaluation with the screening test. In case of test positive, complete with the PREDICT and the CGA, and then we can decide in which group is our patient to focus the management. And that's all. Thanks for listening.